world where cataract surgery is no longer a sight restoring surgery, it's more of a refractive surgery. Calculation of IOL power is one of the most crucial factors for the refractive outcome of cataract surgery. It includes proper selection of IOL material, optimization of IOL constant, informed formula choice, and the use of modern optical biometry. So in my thesis, I have compared 5 standard IOL formulas and 2 artificial intelligence-based formulas with each other. From standard IOL formulas, I have taken SRK2, SRKT, Haigis, Hoffer-Q, and Barrett's universal formula. And from artificial intelligence-based formulas, I have taken Ladas and Hill-RBF formula. Materials and methods. It was a prospective observational study where 100 patients, 100 consecutive patients who underwent cataract surgery from 2020 to 2022 at Government Medical College, Srinagar were taken. Preoperative optical biometry was performed with optical low coherence reflectometry-based lens star. Based on SRK-T formula, single style monofocal standard lens was implanted in the back. Inclusion criteria were basically 3. First was the patient's age, whose minimum limit was kept as 18 years, and single surgeon cases of monofocal IOLs were put, and clear corneal incisions of 2.75 millimeter was given. Exclusion criteria were incomplete biometry, patients unable to go PCI biometry, post-operative corrected distance visual acuity less than 20/40, astigmatism greater than 4, intraoperative or post-operative complication, any previous intraocular or refractive surgery, any corneal disease, or any retinal pathologies. As already said, data was collected from 100 cataract size of 100 patients. The mean axial length of patients was 22.97 plus minus 0.09. Patients were grouped into 3 categories based on axial length, less than 22.5, 22.5 to 24, and greater than 24. Highest number of patients were found in normal, whereas least number of patients were found in long axial length. So results were based on mean absolute error, median absolute error, and mean prediction error. And the conclusions were basically mainly derived from mean absolute error. Across all the axial lengths, Barrett's had the lowest mean absolute error, where SRK2 had the highest mean absolute error. Also, Barrett's had the highest number of patients within the prediction error of plus minus 0.25 diopters. In patients with short axial length, Hoffer-Q had the lowest mean absolute error. Again, SRK2 had the highest mean absolute error. And Hoffer-Q had the highest patients, 45, within the prediction error of plus minus 0.25D. In patients with normal axial length, Barrett's had the lowest mean absolute error, and SRK2 again had the highest mean absolute error. Again, Barrett's had the highest number of patients with prediction error of plus minus 0.2. When it came to patients with long axial length, SRK-T had the lowest mean absolute error, and SRK-2 again had the highest mean absolute error. Again, SRK-T had the highest number of patients within the prediction error of plus minus 0.25 diopters. This is a graph representing the data where we can see Barrett's has the mean absolute error in overall patients and in normal cases, whereas Hoffer-Q has it in short group and SRK-T has it in long group. So from this we can derive, although the Barrett's, Hoffer-Q, and SRK-T had lowest mean absolute errors, the p-values were not that significant when compared to the artificial intelligence-based formulas. So the accuracy of 3rd and 4th generation formulas can be compared to artificial intelligence-based formulas. And as more and more data is being fed into these artificial intelligence-based formulas, we might see an increased accuracy of these formulas. Thank you.
Your study, you have studied mainly 3 formula, no? SRKT.
Sir, 7 formulas.
7 formulas.
Yes, sir.
What were the basically result?
But mainly the axial length and the biometric data of eyes, it depends on the topography of the patients. And in my state in JNK, the results on biometry and axial lengths are the data is very low. So I suppose that is one of the reasons. But also the sample size was only 100 patients.
One of your exclusion criteria was best corrected visual acuity post-operatively.
Yes, sir.
Less than 6/12.
Yes, sir.
So what was the reason you have ruled out fundal pathology or any other pathology?
So some patients have with a high mature cataract, they might be amblyopic or something. So we have ruled out any decrease in vision which cannot be explained post-operatively.
In that, optical biometry was possible or not? Suppose.
No, sir. Optical biometry was not possible in that patient.
So why you have, basically you have excluded?
So in some patients
but
with...
it was taken post-operatively. It would have been pre-operatively. It was taken post-operatively.
Yes, sir.
So if your machine is not recording, then how it was included?
So it was not included in patients with high axial length.
No, his question
But
is
you
why
have
did you
written
exclude it?
post-operatively, na?
Mhm,
You have
yes, sir.
written post-operatively, you have excluded. So
Mhm.
what was the reason? It was included initially,
Mhm.
and then it was excluded
Yes, sir.
due to less base-corrected visual acuity.
Mhm.
So how it was included? If machine was not able to record
So
the
it was not included. Only the
No, then
patients.
he's asked. You said major cataract was the reason why the vision is
yeah.
less than
Mhm.
6. So that is excluded in the inclusion
Yes,
criteria.
sir.
Now, why did you exclude post-operative
Post-operatively.
patients with less than 612? That is the question.
So, patients with longer axial length or patients having amblyopia.
You can't
No,
have
that is
amblyopia
this
initially.
different thing, na?
Mhm.
Basically, you are writing post-operatively. You have excluded.
That
How?
would be all